Thanks for bearing with me, everybody. So I'm Allison Cantway. I am the Assistant Director of Planning and Research at the Metro Nashville Office of Homeless Services. Our office is Metro's newest department. So we are a department just like the health department is, just like the police department is. We were formed July 1st of last year. Now we existed underneath a different Metro department called Metro Social Services, and we had a small team there. But now Metro has decided that they want to, really commit resources and make an investment in homelessness in Nashville. And so they created a full department. Now, our department, we don't really offer a lot of direct services for clients. Really, what we do is help coordinate the city's response to homelessness. So we have some staff that do some street outreach, but we don't have case managers. That's not really what our role is. Our role is to really help all of these different agencies in the city work well together. And we do that under the framework of the Department of Housing and Urban Development, right? The federal office of HUD. So I wanted to give a little bit of background on sort of who we are and what we do. And I know I see that there's several folks on this call who are members of continuum of care in their community or here in Nashville. So this will be familiar for some of you. But for everyone else, so I wanted to start with the McKinney-Vento Act, which was really the first, the only big federal legislative response to homelessness, right? And so it expanded the McKinney Act of 1987. So this is really what gives HUD and gives us the authority to do work in our community. So this is 15 programs that all respond to things around homelessness. So everything that we do under the auspices of the McKinney-Vento Act that gives a lot of folks who are unhoused or experiencing homelessness rights to certain services. And so we operate underneath that. Now, having said that, we also have to operate underneath HUD's definitions, and HUD has extremely strict definitions about the clients that we serve and the services that we can provide. So I'm going to begin, and I say this because a lot of the agencies that work in this space, they are limited in, they can only serve folks that HUD describes as literally homeless, and that's not everyone that's unhoused. Some agencies can only serve folks that meet HUD's definition of chronic homelessness. So I want to tell you what both of those terms mean. So literally homeless, according to HUD, these are folks that they don't have a fixed home, right? So they live in a place that's not meant for human habitation. So that could be a car, that could be the streets, that could be an empty building, something like that. Or these folks are living in some sort of shelter or temporary living arrangement. So anyone who's staying in, in a shelter here in Nashville, if they're staying at the Nashville Rescue Mission, for example, they meet HUD's definition of being literally homeless. And also folks who are, at short-term hotels, transitional housing, that sort of thing. And then literally homeless also includes folks that are exiting institutions that they've been in for 90 days or less, that were literally homeless before that time. Okay, so this does not cover everyone who's unhoused. This does not cover folks that are doubled up or folks that are at risk of losing their housing. This is what HUD decides is sort of literally homeless. And so all the programs that work under the continuum of care have to serve folks that meet this definition. Okay, now the next definition is chronic homelessness. Now this is a little wonky, and I'm not going to get just too far into the weeds of this. But in general, chronic homelessness means that folks have been living in a place not meant for human habitation or in a shelter for quite a while, and also have a disability. You must have a disability to be considered chronically homeless. And so the exact parameters are all listed here. They're very specific. You have to be homeless living as described for at least 12 months or on at least 4 separate occasions in the last 3 years that equal 12 months. So I'm not going to get too deep into that, as I said, But these folks that are experiencing chronic homelessness, we know are the most vulnerable folks, right? They've been living outside for at least a year and they have a disability. So there are some programs that specifically serve them. Here in Nashville, we really prioritize serving the chronically homeless. Okay, now HUD has created a framework by which different communities respond to homelessness. And that framework is called the Continuum of Care. So the Continuum of Care, we call it the COC. It is designed to promote community-wide commitment to ending homelessness, right? So federal dollars come in through the COC. They really work to quickly rehouse folks, minimizing trauma, promoting the utilization of all of the benefits and all of the resources that are available to these folks so that we can optimize their self-sufficiency. So every region of the country has a continuum of care. It might be like, for example, here in Nashville, we have one continuum of care. It covers all of Nashville. That's it. In other areas that are more rural, a continuum of care might cover a few counties. Every place is different, but no matter where you are part or you can be part of, you are within the continuum of care. And the reason why HUD does this, right, is because they know that communities that coordinate their response are going to be far more successful at serving those that are experiencing homelessness. And so HUD really wants to emphasize and encourage everybody working together, kind of as one big unit. Now, this is just an example of the Nashville COC. Again, every COC is different and may be structured differently. But in Nashville, this is kind of the structure of what we have, right? So you can see we have the general membership of the continuum of care, and that's made up of anyone who wants to be involved. So there are lots of service providers, government agencies, but there are also, individual, members of the community, maybe folks with lived experience who want to be a part of, the community-wide response. Underneath our COC, we have all of these different committees that all really carry out the work of the COC, and they all have different functions, right? There's an equity and diversity committee to make sure that we're being equitable with the services that we're providing. We have a veterans work group. You can look here and see, a data committee. Again, different communities have different structures, but this is what ours here in Nashville looks like. And then the continuum of care is governed by the Homelessness Planning Council, which is a board of Metro. So this is what our structure looks like. But as I said, really the continuum of care consists of a network of community partners that are all working towards the same goal, right? That's why we do this together, is because if we operate separately, we're not going to have as much impact. We're really focused on collective impact. So again, this is a nationwide framework, the COC. So I want to sort of introduce a couple of other, nationwide systems that can each be, tweaked to fit your individual community. And again, I know I've got folks here that are members of COCs and are members of these different entities that I'm about to talk about. Now, the first entity that I want to talk about is what we call coordinated entry. So coordinated entry is really the idea of all of these agencies working together as clients enter the system. So it's really like a no wrong door approach, so that clients can get the services that they need. And this is a HUD requirement here in Nashville. So if you're going to get funding from HUD, you have to participate in this coordinated entry process. So, the first step is access. This is how these folks are going to get the resources that they need if they're in a housing crisis or if they are literally homeless. Then they're going to be assessed. So we use a tool to sort of determine what are the different vulnerabilities that a person might have, right? And we use that to prioritize, because obviously resources in most communities around homelessness are scarce. And so most cities and most communities have a way that they prioritize, who is going to get what services. Here in Nashville, we use an assessment tool called the VI SPDAT. It's a nationwide tool. Many communities use it. We are actually currently working on updating that assessment tool because there are some pieces of it that just don't work very well in Nashville, but this is a community-wide process. But again, that assessment is given to these folks to see how do we prioritize them for resources. And then we make referrals based on that assessment of a client's individual need, right? And so those referrals are going to be to programs that are going to be specific to whatever their needs are. So for example, if one of their big needs is that they need some sort of like, I don't know, substance abuse specific program, when they enter the coordinated entry process, as they're assessed and that's determined, then they will be referred to a program that's going to meet that need. And again, this coordinated entry process encompasses a lot of different community agencies that provide these services, and they meet regularly. They meet multiple times a week to discuss, to basically case conference and see, where's the appropriate referral for this client. So now you can see here how clients are referred through coordinated entry, and then there are some things that happen outside of coordinated entry, right? So clients who, are going into emergency shelter, that can go through coordinated entry, transitional housing, rapid rehousing, which is really giving rental assistance. That happens through coordinated entry. Permanent supportive housing, which is housing for folks with a disabling condition, or housing choice vouchers, which is what we call, what folks often know as Section 8. Right, so all of those referrals have to go through the coordinated entry system. And then there are other resources for clients outside of coordinated entry, right? So some folks can access some emergency shelters without going through coordinated entry, same for transitional housing. There are some recovery housing programs that are outside of coordinated entry, rooming houses, these LIHTC properties, and then public housing does not go through coordinated entry. Now, again, this is just a few slides for what is really a nationwide process, but the idea again is, let's assess what the needs of our clients are. Let's have them go through a centralized system that everybody participates in, so that we can make the best referrals and really utilize our resources to the best of our ability. Now, along with coordinated entry is what we call our Homeless Management Information System, HMIS. This is also a nationwide tool, and it's basically one central database that every agency that receives this funding uses in a community. So here in Nashville, we have one HMIS, and all these different agencies in town enter data about their clients into HMIS, right? And so it's the primary source of our data. Whenever we do reports about homelessness in Nashville, we pull all of that straight from HMIS. If we get better data in HMIS, that means that we're going to have more accurate reporting. We're going to be able to structure our programs so that they're strong, but this means that folks have got to be entering data. So, a client could go into a shelter and be entered into HMIS. And then maybe the next day that client goes to the VA to access services. When they do, the VA can see, oh, this client's already in HMIS, and they can see, oh, they're already getting services from these different agencies. So it really helps coordinate services to make sure that we're not duplicating things. It's also a good repository of information, so that, if you're working with a client and they need help getting their birth certificate, you can look and see, oh, they're already working with a local nonprofit to get their birth certificate. So we can work on something else with them to make sure that we're really utilizing all the resources that are available. But we use this to really drive the work that we do. We're extremely data driven. And again, this is nationwide. So every community that gets this funding has to have some sort of HMIS system, and they have to use it to evaluate their programs. And then we report it to the federal government, to other funders. Here in Nashville, we make our reports extremely public. Any member of the public can see the work that's being done. So here's some of the information that HMIS can give us. So whenever these programs, like prevention programs, street outreach, shelter programs, rapid rehousing, whenever they use HMIS and they put in information like client demographics, their history, any barriers that they might have, case plans, disabling conditions, and their income and benefits, whenever we get all of that into one system, we can see who's experiencing homelessness here, How long are they experiencing homelessness? How long does it take for folks to get housed? What kind of housing and services do folks need? Where we're doing things really well and what programs are successful, and then what programs that we can see improvement on. And the next slide is just really an example of like one of the many reports that we pull from this system and that we send to HUD every year. So every year we submit system performance measures. There are several measures. I picked measure 3 to show you. We pulled this from our HMIS system to show some historical context of how many folks are experiencing homelessness here in Nashville. There are different ways that we can quantify that. One is through the point in time count, which is it happens on one night of the year where we literally go out and count all the unhoused people that we can find on the street, all the unhoused people that are in shelters and other programs. Every community in the country does a point in time count. So you can see here, our point in time count has showed that our numbers have ticked up a little bit. We also pull from HMIS how many folks are staying in a shelter. You can see here in Nashville, that number has gone up a lot, right? So that tells us that here in Nashville, more folks are experiencing homelessness, and we can use that information to drive the work that we do. So that is just sort of the basic framework that a lot of these agencies use here in Tennessee, here in Nashville, and in the country, to track and assess homelessness, again, as part of this continuum of care, utilizing our HMIS database and the coordinated entry system to get folks in and then give them appropriate referrals. So that is where I will end my slides, and I will pass it along to Nehru.
Thank you, Allison. And we're going to hold questions for you because we do have to get Nehru off by 2.
Well, thank you so much, Allison. A great presentation there. And I'm familiar with so much of what you shared. And I think the way this is structured is perfect because you really provided a great introduction to a lot of things that you may be assumed. And once I get into some of the things that we do here at the Department of Mental Health for Housing and Homeless Services Program. So hats off to you and your team over there. And I appreciate the information. So I'm going to, and Allison, don't feel bad. I have been in my office for many years and still are having trouble with technical stuff. So you're way ahead of me on this, but I'm going to work to share my screen right now so that we can get into my presentation today. I want to thank the folks at Bring Links to have us here today. It's been an honor to connect with them and an honor to be able to present here with you guys today. So as I get my screen share here. And if I can get some confirmation, my fingers are crossed that
That looks good.
Beautiful.
Yeah.
All right, wonderful. So my name is Nehru Gobin, and I serve with the Tennessee Department of Mental Health and Substance Abuse Services. Currently as the director for the Office of Housing and Homeless Services. I've been in this office now for probably just a little over 5 or 6 years now. Previously served at the Department's Office of Crisis Services and Suicide Prevention, where I served there in a similar capacity for 4 years. Prior to that, worked in the Middle Tennessee area providing crisis response services. And one of the things that I've been able to learn is kind of highlights what our hosts here have talked about, is just really recognizing that a lot of the services in the behavioral health continuum, they overlap the same person, the needs of the same person. So really my experience in crisis services has lent itself to really making sure that we're focusing on what the needs are in homeless services and housing services to help, promote opportunities for greater independence and resiliency and recovery, in the community, so that we can have reductions in hospitalizations, reductions in recidivism, reductions in relapse on substance use. And so my hope today is that I can share with you a little glimpse of some of the programs that we have and how they have helped to address some of the gaps that we know that exist, not only in Tennessee, but across our nation. So just to share a quick caption about our office, we lead the administration, oversight, and management of a current total of 18 different programs, each that aim to provide statewide services by way of contracted community-based organizations to support housing needs and address homelessness for the department's targeted population. We currently have a 6-person team, and we currently manage no less than 160 grant contracts that involve 79 different statewide community-based grantees. Existing programs within our department, I like to kind of categorize them in different groups. Some are centered around infrastructure grants to create new supportive housing. Some really focus on providing permanent supportive housing model-based services. Some are enhanced supportive housing services. Some are homeless outreach services, and some are housing related services. So I'll touch on each of these at this, with this presentation. First, I was going to talk to you guys about our homeless outreach services. Perhaps the most well-known homeless outreach program in our country is PATH, or spelled out as Projects for Assistance in the Transition from Homelessness. This is funded by SAMHSA, which is the Substance Abuse and Mental Health Services Administration at the federal level. And this was a formula grant that is really designed to provide outreach opportunities for folks that are experiencing homelessness, who have mental health needs, or have mental health and co-occurring substance use disorder. In Tennessee, we have a total of 7 different providers that cover a total of 10 different catchment areas. We'd love to be able to see this program expand, that we can touch all 95 counties. And I can tell you that it's a similar sentiment across other states in our nation. And so a lot of discussions are being had about opportunities to increase the PATH resources to be able to expand a really great program. Opportunities are to actually, the folks are, that work this program are actually doing that outreach. They are going out on the street, working in shelters and engaging with folks to try to establish a connection and build a little bit of a rapport that, that incorporates trust, so that they can glean a little bit of information to try to help identify folks who may be out there and need to be connected with mental health services or other types of behavioral health support services, and then see how those avenues can get them enrolled and perhaps get them connected to more homeless housing services. There's a little caption there in FY23 that kind of gives you an idea of the number of individuals statewide that have been served by PATH in Tennessee. You may compare that to the HUD PIC counts and probably say, well, that doesn't cover a lot. But what we're talking about is not just contacts. These are folks that are actually, getting engagement and really building a rapport, so that a lot of times there's increased opportunities for follow-up with the outreach folks that are out there to kind of stay connected with them as best as possible, in a very fluid environment in the homeless community. Another point to make is that, as what Allison was shared with the COCs, our PATH provider agencies engage with the COCs of their region, attending meetings, connecting with them through HMIS, to make sure that data is that's translated from the homeless community, live, is transferred well as best as possible into the HMIS systems. In a similar fashion, we are fortunate enough to have another program that kind of mirrors itself with PATH, but focuses on service to children and youth with serious emotional disturbance or at risk of that. And so we are, again, fortunate enough to have this program. Would love to expand it as well. But we do have 5 community-based mental health agencies. Most of them are also PATH providers that provide these children and youth homeless outreach project services across various different regions. One of the beautiful advantages that for this is that it allows the outreach workers here to really kind of have opportunities to engage in local school systems or identify, children who may be in homeless situations with their families. And so there are opportunities, for example, for financial support in a limited sense to try to help keep that family whole and reduce a length of time in which they may have to continue to be homeless, or even to get those children enrolled. And a lot of times, because those children are with their parents or guardians, that may help identify needs for, a family member, whether it's that parent or a sibling or what have you, to get connected as well into services. So it kind of has a multiplier effect that we have this program. And I'll step a little bit into some of the aspects and the different programs that we have either at our office or within our department. As we know that, folks as homelessness, one of the biggest challenges is financial challenges. Whether we, the gaps that exist, that even in certain areas in our state, we know that quote unquote affordable housing is not always affordable, at least not for the folks that we're serving. We're fortunate enough to have two programs within our office that really provides opportunities for specific financial assistance on a short-term and limited basis to individuals who are homeless or at risk of homelessness, who may be living with mental health or substance use disorder, such that they may be one rent deposit payment away or a couple of months rent payment away from being able to secure housing. And perhaps there are certain things that may be on its way. Maybe they're waiting on a disability income application to be completed and approved. Perhaps they have a job lined up or something that their prospects are job opportunities or assistance in that way, is along the way, but they need that gap so that we can reduce that time period in which they are homeless or at risk of homelessness. We have folks who are, being served who may be in a place, but a circumstance has happened or that has, put them at risk, that if they don't have a means to cover a certain expense in that moment that's critical, that this program has been able to help. So in this program, we have it broken up into two separate programs. One is known as Community Targeted Transitional Support, or abbreviated CTTS, and that focuses on folks that are currently in the community. And we're fortunate enough to have 16 different provider agencies, community-based mental health agencies in Tennessee that we work with to provide this service. Our numbers and ability to serve in this program continues to increase each year. In the last fiscal year, we've had over 3,000 individuals served with this program. In a similar fashion, we also have this model used to support discharges from our state's regional mental health institutes of psychiatric hospitals. And so this particular program, inpatient targeted transitional support, really works with, again, community-based organizations that interface with our 4 regional mental health institutes across the state, so that we can get folks who are clinically ready to be discharged, but again, may not have that first rent payment. A lot of the social workers at the hospitals may have an opportunity to secure an opportunity or a bed at a quality supported living home, but that person, because they have been in the hospital for an extensive period of time, may have met their income benefits may have been suspended, for example. And so this covers that gap to help cover and make a payment or two that can support that means, to make sure that person does not have to remain in the hospital longer than what is clinically necessary. Again, our numbers continue to increase in that way, with over 2,500 individuals served in the last fiscal year. We're fortunate because we've been able to understand that we're continuing to try to meet the need. So a lot of different types of services or needs that are out there to get people housed beyond rent, beyond utilities. For example, a lot of folks may need their ID. Some opportunities to seek housing requires that, and they may not have the means to even pay for that. We've been able to support that effort as well. And so we're excited about being able to be a part of a program that continues to try to find opportunities to broaden its scope. One other thing that I think that we know is a bit of an elephant in the room, I think that we all experience, and I wanted to touch on, even though this is not directly from our particular office, but it is from our department, is really to emphasize the importance of employment and work. We've identified through a lot of research that has been gleaned that a lot of people that are living with mental illness, they want to work and they have the capacity to work, but there's such a small percentage that are employed. And, we've learned a lot that, from the community and from research that, employment gives folks, even though, including those that live with mental illness and substance use disorder, gives them purpose. Of course, a practical means to cover those expenses that we all need and we all need to be able to cover. And so one of the things that our department has done for years now is to incorporate an Office of Wellness and Employment. Within that office is a program known as IPS, Individual Placement and Support. And what that program does, it really centers around services that target an individual that may be living with mental illness or substance use disorder that has a desire to work. And the belief is that if they want to work, they can work. And so and with this program, it is designed to have specialists work directly with folks who are interested in working and help create plans and opportunities for them to support needs to allow them to pursue employment opportunities of their desire, match that with their skill set and their abilities, and support them as to where they are. The greatest thing about this is of all of the points that are really of high integrity with this program, one being zero exclusion, which is that, there is a concept in our community that we all know that we may conclude that someone's not really ready to work, that they have to get stable first or what have you. This model basically says that, we don't have to wait for those types of things to get them started in this service and work with them to get their needs met from an employment perspective. And so it has been proven to be very, very effective. We're fortunate enough that our department, the Office of Wellness and Employment, has increased its expansion of the IPS program, and they're undergoing an expansion now. So if they have any interest with this, we'll be happy to provide you with links to our department's website about this particular program and opportunities to connect you with our office and my colleague, Director Mark Liverman, on this. Speaking also for opportunities for income is the SOAR program. Some of you, many of you are probably familiar with SOAR, but for those of you who are not, SOAR stands for SSI, SSDI, Outreach, Access, and Recovery. This program is a best practices model implemented by the Substance Abuse and Mental Health Services Administration at the federal level. And each state kind of incorporates SOAR in some capacity to its community. This is basically a model that is designed to increase access to disability income by working with individuals who are homeless or at risk of homelessness to help them provide a more effective and more comprehensive application that increases its success for approval on the front end. Those of you who have worked with individuals trying to apply for disability income with the Social Security Administration on behalf of someone will know that oftentimes for many, many years, it's just been assumed, you might as well prepare that you're going to get rejected this first go. Some have even learned that they are only going to be able to get approved unless they secure an attorney. We're fortunate enough that SOAR, implementing this model, we know that has defied those types of odds. This program actually works and has really been proven so effective such that we're having folks that getting applications done using the SOAR model on the first go and having record turnaround on getting approved for this income. The SOAR Liaison Program in particular is a program that our department funds. that targets this model for folks coming out of our regional mental health institutes. One of my personal dreams is to be able to fund this for the community. But with that, our office is still working within the community, statewide community, through the PATH program and through our state SOAR lead here in our own office to basically try to galvanize interest in SOAR. The beauty of SOAR is that to become trained to help someone apply for it is free of charge, is a self-paced training. And so we always encourage organizations to consider assigning someone in their staff to become SOAR trained to assist, even if they assist one person at a time or two people in a year. Those two people will have a greater opportunity to get connected to this resource without, as if you didn't have it. So we're always trying to plug SOAR to try and encourage folks because we know it indeed works. This slide here kind of shows you the latest national outcomes from SAMHSA. And I'm proud to tell you guys, I think for the first time that, or at least the first time in a very long time, that our state of Tennessee is #1 in the entire country in SOAR outcomes. And so we know for a fact this works. And so for any interest, we encourage you guys to reach out to our office so we can share with you about this model and how you can make this work to support your community. Another program that we're fortunate enough to have incorporates peer specialists, certified peer recovery specialists. And they are, as we know, peers are folks that haven't, that are fortunate enough to use their lived experience to impact those that they know, they're familiar with their path, and are really interested in walking with them towards their opportunities for recovery and resiliency and greater independence. The Consumer Housing Specialist Program is part of our Creating Homes Initiative program, which I'll touch on in a little bit more detail in a moment. But this particular program enlists currently 4 positions statewide, and they're regionally based, that are a portal of sorts for folks who are seeking out assistance in trying to identify what housing resources that may exist in their area. This could be, as it relates to housing vouchers or affordable housing opportunities, in their area. They're also providing a lot of education information to the community, trying to break down some of those barriers that we know that exist, that may be commonly known as not in my backyard. There's a lot of myths out there, but, for individuals who are homeless, individuals who are living with mental illness, that is sometimes associated with a propensity for violence, for example. And we really work hard to try to dispel those myths so that we can understand that some of the barriers that are unintentionally created in our community can be resolved. And by providing that education and information can help lower those barriers so that we can overcome that. So I like to consider our specialists as some unsung heroes across our programs in our department. So as I mentioned, I was going to touch on the Creating Homes Initiative. This is our flagship program for our office. I'm sure many of you have heard about this, and some of you probably haven't. But the Creating Homes Initiative is a model that's been in existence for about 24 years now, created by our current commissioner, Ms. Marie Williams. And basically, it is a model that seeks to assertively and strategically partner with local communities. This is at the city level, the county level, the state level, what have you, to essentially work to expand the stock of quality, affordable, permanent housing for individuals living with mental illness and or substance use disorder. This model is implemented really in the community level by our regional housing facilitators. And what they do is they're really out there, beating the pavement, connecting with organizations and interested stakeholders that want to really expand the housing, the breadth of affordable housing in our state. So they'll collaborate, they work on writing grants, they actually connect with the HUD COC organizations and groups in their respective regions. They will sit down with them with agencies that are interested in creating that to help with strategies. Also to help apply for grant opportunities that are coming out of our department for new infrastructure creation for supportive housing. So we're fortunate enough to have 7 regional housing facilitators statewide that focus on creating housing for folks who are living with mental illness. And then we also have, in the last few years, we've been able to expand this for regional substance use housing facilitators so that they can generate a new focus on creating housing opportunities for folks that are in recovery from substance use disorder. Even though we have this delineation, many times our facilitators are working together on projects in their region. We really have, in spite of the distance, the geographical distance, we really have a unified group of facilitators that do excellent work in each of our 7 regions across the state. So this slide I wanted to use to kind of share with you a really real-time example of partnership even within our Creating Homes initiative. So when the Creating Homes initiative started in the year 2000, our leadership here reached out to the Tennessee Housing Development Agency to share the vision, and at the time the leadership of THDA was excited about it and decided that they would provide a match to to increase that seed funding opportunity to launch the Creating Homes initiative. 20 years later, we just had so much fantastic success that our department's leadership had decided to go and request an opportunity to add new recurring dollars, to expand it, to add a new focus on recovery housing. And so we were able to do that and branded that expansion as CHI 2.0. Once again, our department's leadership had reached out to THDA and said, hey, remember what we did 20 years ago? Let's do it again. And we're fortunate enough that Executive Director Ralph Perry and his team was excited to be a part of that, knowing the great work that was done on the first time, and went ahead and provided a $3 million match to launch this new expansion. When they generated their funding announcement, they got a lot of quality competitive grants, and a total of 74 units were created as a result of their contributions to CHI 2.0. Also with CHI 2.0, we have seen with that expansion, we've actually seen some continued success over the last few years, such that to date, as of the end of the last fiscal year, we've had 35,000 housing opportunities created with more than $1.2 billion leveraged since the beginning. And this has been so phenomenal over the years that we've seen in the last several years that we've had these new state investments. This is the one I mentioned with you in year 2020 with CHI 2.0 for addiction recovery. But then also, as recent as 2 fiscal years ago, fiscal year 2022, to add a new focus on individuals living with mental illness and substance use disorder who are reinserting our community from prisons and jails or justice involved. And so we've been hot and heavy with receiving a lot of grant applications for that, because we have gotten some new dollars to be able to expand that. And so this is just give you a profile of those 2 programs there. And that snapshot there that shows you on the far right is actually just an image of the quality types of housing that we're providing. That is a living room for a new home in Jackson, Tennessee by one of our really reputation organizations that we work with, known as Asper Recovery Center. And they provided quality housing with this grant to serve 12 women who are in recovery. So this is just a snapshot of a living room that's been established as a result of what they've done. And then they've leveraged by the name they're given, Kirkland House, connected with the family member of the Kirkland store that you guys may be familiar with. And they donated some beautiful furniture towards the home. So that's where that leveraging, effort comes to. And so we've just seen that just expand and grow across our community. these are the 3 grants that we've been fortunate enough to release in the last few years. We've been able to do this on an annual basis since the year 2020 with these 3 grants. The Creating Affordable Housing Grant is an infrastructure only grant that folks can apply for to create the infrastructure for supportive housing. And the CHI 2.0, as I mentioned, is for recovery housing. We were fortunate enough to also have recurring dollars with that particular grant so that the infrastructure dollars could be paired with recurring operational money to kind of keep support services funded at those homes that are being created. And then again in 22 with CHI 3.0, that focuses on the reentry population, again with infrastructure and operational costs. We had seen last year was such a huge turnout for interest with probably about 80 different grant proposals statewide that came in. And so because of that, and we funded as many as we could to make sure that we were going to expand the breadth of housing that was going to be completed for our population, such that we now know that with CHI 2.0 grant funding, we've been able to commit all of the funds to create new housing and to support services there. So it was a really a celebratory moment for us to be able to do that and to prove its success, to kind of use this to kind of to continue to advocate for increased opportunities to provide new grants. So now I'm going to step into some of our programs that really focuses on the permanent supportive housing model. And basically it's the permanent supportive housing model really speaks about the core of it is about the wraparound services, access to services that will help someone living with mental illness or substance use disorder have the resources and tools either at the home or access to them in their community that will increase their independence, increase their opportunity to retain that housing, reduce their need for rehospitalization or the chances for them for relapse or recidivism. The community supportive housing program has been in existence for quite some time now and really focuses on that permanent supportive housing model for folks who are living with with mental illness or current mental illness and substance use disorder.
I just wanted to jump in and remind you of the time. It's 2 or 2:01 Central. I just wanted
Thank you so much. And
You're welcome.
I'm going to apologize to my
We
next
didn't want to
group.
keep you too long.
I appreciate it. I'll get through this a little bit faster, guys. I'm almost done here, and then I will apologize to my other group. But just to give this audience what they deserve on this bill, I'll make sure I complete. The supportive recovery housing is derived from the CHI 2.0 grant that we shared. Again, uses wraparound recovery support services to cover the folks that will be residing in these homes to help prevent relapse, provide peer recovery, support employment access, and encourage them for community engagement so that they can have successful connections with the community. The home that you see here has been recently completed. This one is also in West Tennessee with an agency that was new to us in the last fiscal year. And they really put together a beautiful, beautiful home to serve 12 women who are in recovery, and also to provide opportunities for those women to have their children live with them as well. And so it really helps to see families that have opportunities to stay intact. Again, in a similar fashion, as a result of the CHI 3.0, which focuses on reentry, the supportive reentry housing program is that wraparound services support opportunity through the programming that we have here to provide that support for individuals who are residing in these homes who are reentering the community from prisons, jails, or justice involved. And so this particular home is in the Nashville area and providing housing for men who are I think it's about 12 or 14 beds on this particular home. And so we're seeing more and more really high quality homes that are really encouraging other folks in the community to say, well, I don't really mind having this type of home in my community. And so that's what we're interested in, because we do believe that it's going to continue to help break down some of those barriers there. We're really unfortunate about that. So we're actively working with grantee agencies to complete new housing that are in the works right now. And then you might have recalled me mentioning earlier that we also have enhanced support programs. We have two here that is really special for us. And the first one has been proven to be very effective for quite some time. That's known as the Intensive Long-Term Support Program. That program uses our highest licensure type for non-treatment based housing that provides supportive housing for Tennesseans who are discharging from the regional mental health institutes. These are folks that are living with severe and persistent mental illness. So a lot of the folks at the hospital that are coming into these facilities, they've been in that psych hospital for a very long time. Most cases, this because that there hasn't been the type of housing that supports the needs that they have. So we've been fortunate enough to be able to create a program and fund this program to establish that type of housing, to provide access to clinical supports, on-call doctors to help prescribe medications when needed, to kind of reduce perhaps a episode of behavior that may otherwise might be called into crisis or what have you. We've been able to see that. We've had recent expansions to add a total of 41 new beds. One of those in Jackson has just been completed in the last few months and is in operations to serve discharges coming from the Western Mental Health Institute in rural West Tennessee. And then we're close to completion on a new site in Chattanooga to serve Moccasin Bend Mental Health Institute in Chattanooga for 21 new beds, and that is close to completion as well. So we'll have a new capacity for this program at just over 150 beds. In a similar fashion, we've just launched this fiscal year the residential reentry housing program. So it's kind of a blend of the ILS program that you see at the top and the CHI 3.0. That's the way I've kind of fashioned it, where we're targeting individuals who are coming out of correctional facilities, or the folks who are just as involved, so like CHI 3.0, but also those who are living with severe and persistent mental illness. So a little bit of it higher than what we may typically see in some of the more traditional types of permanent supportive housing settings. So this is underway right now. We've released a funding announcement this year. We received a total of 7 competitive proposals. 3 of them were selected for funding. So we're building contracts now to create the infrastructure that will ultimately create 54 beds. At some point, perhaps in the summer, we'll be releasing another funding announcement so that we can get our entire vision complete, which is to launch a total of 108 beds. So that will be 3 more projects, and there will be 2 projects, or 2 new homes in each of the 3 grand divisions in Tennessee. So stay tuned for that. You'll see once we get that up and going. I do know our friends at the Tennessee Department of Correction and other organizations and entities that serve the justice involved population will be really excited to see this launch. So as you can see that we've been able to identify certain gaps that have been in existence and really work hard to cover those gaps. And I can assure you that our department and our department's leadership really works hard to kind of listen to the community and explore what opportunities, the best opportunities to advocate for expansions or creation of new programs and to secure the resources to be able to do that. I apologize in advance for having to depart soon, but that is the end of my slides. This last little photo here also shows you that depending on the proposals that we receive, folks are saying, hey, we're some people with mental illness, but we want to send around folks who are veterans. And we were excited about that. There's an organization in Montgomery County that created beautiful apartments for veterans. We're living with that. So we welcome, opportunities to get more specific for those who are living with mental illness and substance use disorder. But again, Wendy, I thank you. Jennifer, thank you for the opportunity for me to present. There's a lot of information there, but please be encouraged to share the slide deck with our audience today, and they can reach out to us for any questions.
Thank you so much. We know you have to run. Much, much appreciated.
Absolutely, absolutely.
Very much. I'm always just amazed each time we do this at the just the incredible infrastructure that we have for all of these different things that I just don't know about. So hopefully you're all learning that as well. And we're gonna go quick to Jeff Craig, and I'll let you introduce yourself.
Thank you, Wendy. Hi, Jeff Craig here, Coordinated Entry Specialist with the Memphis VA Homeless Program. And Wendy, what is the time allotment that you would like me to?
Well, if you can get it done in 10 minutes, within 10 minutes, and then we'll still have time to any discussion and
Okay,
close things out.
I'm going to set my timer for 8. And
Okay,
see how we go.
it depends. Is Lakeisha also going to be talking, or just you?
We're going to share just or divide just slightly.
Okay.
Lakeisha's going to cover outreach specifically.
Okay.
Like, we'll see.
Jump right in. Jump
Okay.
right in.
Let me see if I can negotiate my PowerPoint to do what it is that I need it to do. Oh, let me start by sharing screen.
Perfect.
Okay, can you guys see what you need to see?
Yep. Perfect.
Okay, basically, Lakeisha and I are going to, in 10 minutes or less, give you an overview of the Memphis VA Homeless Program and our services and points of contact. It is going to be very much an overview. We could talk for 5 hours or for 5 days about the programs and services that the VA offers to homeless veterans. I want to preface everything I share first by also acknowledging the explanation of the continuum of care that Allison provided. We are part of that continuum of care. And I want to acknowledge Roseanne Downing, who is on this call, it looks like as well, who is one of 2 of the continuums of care that the Memphis VA interfaces with. She covers West Tennessee. And I just want to say, hello, Roseanne. Thank you for being here. We could not do what we do at the VA without the full-on collaboration and participation of our continuum of care partners that are out there all across our service area. And I also want to preface everything that we will be sharing by letting you know that every VA has these programs and services available to veterans. I think there are 152 VA healthcare systems in the United States, and everyone has a form or fashion. Of course, each VA delivers services in unique ways. We do intakes Monday through Friday from 8 until noon for HUD-VASH, and we do intakes from 8 until 2 in the afternoon for GPD transitional housing. That's just how we do it. Nashville may do it entirely differently, but the benefits and programs and services that are there at the core available to veterans are the same across the country. So what do? We are here to serve veterans who are literally homeless, who are at imminent risk of becoming homeless, or who are unstably and unsecurely housed. That can mean lots of different things. The first thing that we do when we encounter a veteran that is homeless is we verify that the person is a veteran. I won't go into all of the details except to say that the veteran does not have to be eligible for VA health care. They only have to be a veteran who can be identified and whose service can be verified so that we know the person is a veteran and that they do not have a court martial or a dishonorable discharge from active duty military. So once all of that is done, we come alongside the veteran, however he or she is identified, whether it's through one of our community partners through the continuum of care, or whether it is from our outreach staff, or whether it is the veteran walking through our door to request information and services. We first of all explain to them the two programs that we operate for housing. One is entitled and known as Grant and Per Diem Transitional Housing. The reason that Grant and Per Diem is there is because the VA offers lots of different types of housing programs, which could be for PTSD, for short term, or for drug and alcohol treatment, which would be short term, and very transitional. The Grant Per Diem is named that because the programs that house the veterans are funded through VA grants. They are not operated by the VA. They are independent organizations operating under their own policies and procedures and boards of directors, and they receive a VA grant to do Grant and Per Diem. That's a short-term housing program. It's congregate living. There's 24-hour security and safety provided for the veteran, 3 meals, snacks, case management services, and just a full continuum of care and services designed to try and help the veteran establish a pathway to housing and then implement that pathway to housing. The other program is known as HUD-VASH Housing Choice Voucher Assistance Program. That's a partnership with HUD, Housing and Urban Development, Department of Housing and Urban Development, and the local housing authorities, where we facilitate helping the veteran complete an application. We submit it to the local housing authority. It takes about 10 to 14 working days for them to be issued a voucher. They have a range of a dollar range with a low and a high. It could be 900, could be 800 starting, could go to 1,000, could go to 1,100, but they have to stay within that range, and they can take that voucher and go search for housing, which we help them with as well. And that is permanent housing because the veteran will sign a lease and will be sustainable once they have achieved their voucher and found housing. We also offer veteran justice outreach and legal assistance. We also offer employment services, peer support, outreach, which is coming, and coordinated entry, which is my role, is working with the veteran and with the partners in care all across our continuum. And I'm sorry, I've already delivered and shared what the VA Grant Per Diem Transitional Housing Program is. That's what this slide is. I've already discussed what the HUD-VASH Housing Choice Voucher Program is. I didn't mention this. Our philosophy is one of housing first, and our approach is one of housing first, which means basically the veteran does not have to commit to becoming sober. They do not have to commit to entering mental health treatment. We would like them to do both of those things if those are issues for them, but because we are a housing first philosophy and approach, we do not allow that to be a barrier standing in the way of helping the veteran identify a pathway to housing and us offering them the resources that we're talking about. Points of contact for the Memphis VA Homeless Program. There's myself, coordinated entry. There's my phone number. Our HUD-VASH coordinator, Pam Carroll, is listed there and her phone number. And I'm going to turn this over now to Lakeisha Heron, who is our urban outreach point of contact for the Memphis proper area. And I believe Ms. Sheila Martin Woods may be on this call as well, and she is the rural West Tennessee outreach person. So Lakeisha, Sheila, if you guys would like to jump in and share what you guys do in the way of outreach, please feel free.
Thank you, Jeff. Um, this is Lakeisha Heron, and I am the homeless urban outreach social worker for our homeless program. And my primary catchment area would be all of the urban areas of Memphis and Shelby County. I visit local shelters, hospitals, clinics. I do receive phone calls where there might be homeless veterans who would meet criteria for our transitional housing. I go to them personally and complete the intake. Um, I assist with the enrollments and referrals and do a brief assessment. And we do enter these things in our homes system as well. Um, we provide referrals, like I said, not only to our transitional housing, but some veterans, they don't want to do transitional housing. They might need food services. So we do provide resources for local community health, food, clothing, hygiene services as well. Sheila should be on the call. However, she and Ginger Kathy, our other outreach social worker, they more so cover the rural areas, which would include West Tennessee and Arkansas. Ginger covers our Mississippi region, so that would be Oxford, Tupelo, um, as well as some of the other rural counties.
Thank you, Lakeisha. Appreciate that. Okay, I think we will stop there.
Thank you so much. And Jeff, I want to clarify, when we had a conversation, I believe that you told me that if anybody in any system of support encounters a veteran who needs services, regardless of which other system of support they need it from, they should direct that person back to the VA. Is that true?
That is correct. Now, if the person knows that they're not eligible for VA health care, they still need to, well, let me back up. If the veteran is unclear in his or her understanding of whether they are eligible for VA health care, then yes, direct them to their local nearest VA or VA CBOC outpatient clinic, of which there are numerous spread out mainly in the rural areas, so that they can go and approach that VA system to find out if they are or if they are not eligible for VA
Okay.
health care.
Okay, thank you. And thank you for sharing all of that. If you'll stop sharing, I'm just going to share for a moment a little bit of the intersectionality with brain injury, just real quick. And we have about 9 minutes left.
Sorry.
No problem. And that's
Still sharing?
Yeah, there you go. Perfect.
Oh, sorry. I think I clicked it again.
Let's see. I may be able to.
Looks good.
Perfect. Okay. All right.
You might want to swap your view.
I think what I'll do is just leave it here for now, just in the interest of time.
That's fine.
Yeah. And just go through a little bit real quick about homelessness and traumatic brain injury. So over half of those who become homeless or are in an insecure living situation have a TBI already. 25% of those are pretty significant brain injuries, moderate to severe brain injuries, and that's 10 times higher than the general population. And those folks are in poorer general health and functioning than people who are homeless without a brain injury. And more than half experience their first TBI before becoming homeless. So there's also a substantial number who experience their TBI after becoming homeless, because that's a risk factor for brain injury. But often it's before. So again, we have to be looking at brain injury and doing a better job at that throughout, like screening, so that they don't get to the point of having difficulty. They're more likely to report, people who are homeless, that they have a TBI, are more likely to report childhood trauma or violence, and traumatic brain injury is both a cause and a consequence of homelessness. And then they have poorer outcomes, people with TBI, with self-reported physical health, mental health, higher suicidality and suicide risk, memory concerns, and increased health service use and criminal justice system involvement. And so just like with all of the other systems, people who are homeless with a brain injury have common cognitive challenges and other challenges. I'll let you read them there, and they will also, those types of things will also be on those infographics that I talked about. And then the difficulties there in that big circle can make it harder to budget, to apply for housing, pay rent, hold a job, all the things that are required to stay housed and to become housed. So we need to be screening within the homeless population, screen for prior history of brain injury, screen for cognitive and other deficits, teach them to use accommodations, and that can take a little bit of time, and then follow up more often with them and longer with them once we identify the TBI. At this point, we're going to stop. We're not done just because I'm showing you the survey. We have a few more minutes to be able to talk about whatever you all want to talk about. But before we stop, or as we stop recording here, the people who are on the recording listening can fill out our survey and get a certificate for attending. All right, so let me stop sharing right there and open it up to anyone with any questions, any comments. This is our discussion time. What kind of changes